Opening a central line kit is pretty straightforward. Using standard sterile procedure, you want to make sure that it's open and draped with the exposed sides to non-sterile fields laying down on the sides of the table. Once it's opened with your bare hands, you can go ahead and switch into surgical gloves. Once sterile procedure has been used to put on a gown and gloves as appropriate, you can go ahead and open the kit and move the drape to the other side. I like to open the kit first to make sure everything that I need is in the appropriate position. So this is a good time to go through what should be in the central line kit. There's a small gauze pad, usually a large gauze pad. We're in a lidocaine shortage right now, so we have a separately packaged lidocaine, but usually there's a little glass ampule of lidocaine that goes in right there. There's guide wire. There's a needle to draw up the lidocaine, which you're going to use to anesthetize the patient. There's a second 5 ml needle that has usually a 20 gauge needle attached to it. This is for administering deeper lidocaine, especially if you're going to do something like a subclavian or a supraclavicular line. You have a blue syringe with your actual needle attached to it, which is what we're going to be using to cannulate the vessel. There's a set of needle drivers and a suture kit, an instruction pack, a scalpel, which I like to open and stick in the foam pad for sharps. Then there's your central line. Central line has 3 ports, 2 ports or 1 port, depending on the type. Some of them are even quad lumen. But they all have a brown port. The brown port is the port where you're going to be accessing and retrieving the the wire, when we actually put the wire in. So I like to take the cap off of that and get that ready. There's a skin dilator. And there's a larger cannulated IV if you want to put a second line in as a backup. Finally, there's your date expiration for lidocaine. There's a foam anchor and a snap, which are designed to secure the line into the patient. That's your standard central line kit setup. What I like to do next is actually take the area of the patient where I'm going to be putting the line in and get them prepped with ChloraPrep. In order to do that, you want to squeeze both sides of the lollipop and let the sponge fill. This is a mannequin, so I'm not actually going to stain the mannequin, but basically that's how you would do it. And then we're going to go ahead and get the patient's area scrubbed. Right? What I like to do is generously use the ChloraPrep in the area that I'm planning on placing my line. In this case, it's going to be the subclavian on the right side, as well as the IJ. This is going to allow me, if I need to reposition the sterile drape without having to change my sterile field, and also at the same time rapidly find a different location should I have difficulty getting access in one area or the other. A lot of times anatomy can vary. Different people can have overlying arteries or different veins, or sometimes they're old, they have cartilage that's a little more overgrown than others, and sometimes there's just other complications that get in the way. The next step is to open up the sterile package. That contains the actual drape for the patient. We've already we've already cleaned the patient. You peel this apart. Obviously, there's a part that says head. Since we're going to do a subclavian location, I want this circle with the sticky plastic to actually go around the field where I'm going to be putting the line. So I'm going to place the head towards the head with the circle straight down, and then fold one side towards me, and then they both fold out towards the other side of the patient. Grab the arrow where indicated and pull until it falls down the side of the bed. This tab here is designed to go over the patient's head. Notice there's a window for the patient to actually be able to breathe and see. And then this side is designed to go straight down to the feet, all the way, to cover the entire body. Once the patient's been draped, at that time I like to go ahead and get the patient nice and anesthetized. So what I'm going to do is open my lidocaine kit. Draw up some lidocaine. And depending on where I am, I'm going to be anesthetizing the patient deep enough to get most of the major structures where they need to stay numb. For the subclavian line, I like to identify my landmarks. First I find the AC joint, then I find the sternal notch, and then I identify the length of the clavicle. By definition, the subclavian vessel is sub or below to the clavicle. I'd like to take the needle full of lidocaine, inject it along the course where I'm going to be anesthetizing the patient, put a little bit in, move along the length of the bone because the bone is very tender and sensitive, and then I like to go around while I'm gently aspirating back on the syringe to make sure I don't get in the vessel. Once I get deep in, I like to slowly inject lidocaine as I'm withdrawing the needle. This allows good coverage along the entire length of the subclavian bone. As the lidocaine's in there doing its job, this is a perfect time to make sure I'm set up for the entire procedure. And I like to lay things out in the opposite order that I'm going to be using them. That way I can grab them and go and know exactly where I am in the procedure as I go. So the first thing I'm going to do is take the central line with the cap off of the brown introducer and lay it on top of the patient. You doing okay? He's doing great. The next thing I'm going to do is take my dilator and put that right next to the central line. That way I can grab it and I know it's there. Then I like to remove the cap from the wire and the back cap from the wire that can sometimes hold it. And then I like to test it to make sure that it moves. This one moves just fine. I'll lay that on top of everything right there because that's the first thing I'm going to grab after I find the vein. Then I like to take my suture, load up my suture with my needle driver, take it out, center it up so it's right where I know I'm ready to throw the first knot, and then bury the needle into the sharps foam. Notice it's ready for me to grab when I'm ready to use it, and I already have the scalpel ready as well. Now, I noted earlier there were 2 syringes in a central line kit typically. I like to use the clear syringe. I personally think that the blue syringe has a metal interior, and that has a little bit of an interesting draw to it. It doesn't seem to have as much resistance as I would expect to see when I'm actually putting the line in. And I like to know that resistance is there from the fluid so that I know I'm not anywhere near other organs, especially the lung if I'm doing an upper extremity line. So I'll take the central line needle off of the blue syringe and put it onto the clear syringe. Next thing I like to do is hold the needle in the position I'm going to be drawing it, because every time you do a procedure with the needle, you should be gently aspirating on the syringe itself to make sure that you're not in an area where there's air. As a style point, I like to take the beveled edge of the needle and place it on the syringe so that the bevel is actually open towards the heart which is where the wire is supposed to go, and eventually where the line is supposed to go. This bevel actually helps guide the wire into the right location. Once the patient is anesthetized, it's time to start the procedure. All right, so at this time our patient is numbed, they're draped, they're cleaned, we have everything set up the way we want it, we have our needle and our syringe ready to go. Let's walk through how to put in subclavian line. The first thing I like to do is find the acromion, so I know I'm at the distal end of the subclavian. Then I like to find the sternoclavicular notch, which is where the sternum and the clavicle meet. Then I like to trace the actual bone with my thumb so I can see exactly where the anatomy lies. Some people, believe it or not, have thicker clavicles than others, different positions, prior injuries. Some of them have had fractures in the past that have a big fracture knot, and sometimes they have injuries underneath the bone that you can't see, which can make the line sometimes a challenge, especially in the elderly, where there's arthritis and scar tissue and numerous other things that kind of come into play. Once I have an idea where I want to go, I take the needle as shown before, beveled down facing the heart, with the actual elongated, or narrow I should say, end of the rectangle up for my thumb. That way I can aspirate as I go in. That's how the motion should go. At that point, you simply find a location that you can put the needle in. I like to go at about a 45-degree angle. Any deeper than that's a little concerning to me because right underneath where I am is the lung. Then I like to angle the needle and push it straight in until I hit the bone. Always, of course, aspirating, and then slowly walk it around the bone. It may take a couple pokes before you get it in the right spot. But basically, once you're in, you're gonna know, because that syringe is gonna fill very rapidly with blood, which is what you want. This is also why we numb the patient. You know you're in when blood starts coming out. Once you're in the vessel, you want to remove the syringe, take your wire, and insert your guide wire into the vessel. Now this is a simulator, so usually if it's venous blood, it should dribble out. It shouldn't pour out like it is here. You want to run your wire in. You'll know it's going in because it feeds nice and easily. Okay. Once the wire's in, you can safely remove the needle. Now, this is called Seldinger technique. Seldinger technique was named after a very smart physician who understood that he could actually run things into vessels using an over-wire or guide-by-wire technique. I'm a neat freak, so I like to make sure everything's clean on my field. Others aren't, but that's okay, to each their own. The next step is to take your scalpel, make an incision along the wire, big enough for the dilator to go in. And go a little deep, like so. Now in a real patient, this may bleed a little bit, but it's a very superficial. Grab your dilator, which is again conveniently placed where it is. Run it over the tip of the wire, into the incision that you cut, and it will go into the vessel that you cut as well. You know that your dilator is in when it is hubbed completely like that, at which point you can then remove the dilator and then run your line over the dilator. As you get close, what you want to do is kind of use this pinching and pulling technique. It'll inch the line out. And you'll eventually see it come through the tip of the brown port. It's almost there. So like that. Once the wire's out, hold on tightly and simply slide the line over the wire. Goes in a lot easier on a human than it does on a mannequin. Now for style points, when you put the line or pull the line out, the wire, I like to actually put it back into the circle container so it doesn't splash anybody else that may be helping you with your procedure. And then you simply pull it out. Central line is placed. You want to make sure that blood flushes and that each line is filled and flushed with saline. This would be the saline flush. All three ports are able to draw blood. You want to back the tube out, the line out, to the second mark, right there. And you can see that it says 15. That's 15 centimeters, because the rest of the line is going down and should stop right around there, which is right towards the atrium of the heart. Then you place your white and then blue cap on. They snap onto each other like so. Take your sutures, which we got ready on the last video, and tie the line in place. You can tie it however you want. I prefer to use a two-handed knot tie. Some people like the instrument tie. For me, it's just quicker and I'm used to it. Put a few throws in. Hold both of your lines. Cut them with the scalpel. And do the same on the other side. Once the line is secured, use your hospital-specific protocols to place a sterile dressing on top of it, and then get a chest x-ray to confirm the line is in fact in the right place. Sometimes lines can go up, sometimes they can go down, sometimes they can actually go into the heart, and if it's too deep, that can cause a problem with the valves. So you don't want that to happen either. I hope you enjoyed this video, and I hope that this helps your clinical practice. Have a great day.